Hello everyone, let's see short and sweet topic of pharmacokinetics, that is excretion, which is the part of elimination. So what is excretion? Excretion is the passage out of systematically absorbed drugs. Drugs and their metabolites are excreted in urine and feces. In urine, drug excretion in urine occurs via kidney. It is the most important channel for excretion of majority of drugs. Then feces. Apart from the unabsorbed fractions of the drug present in the feces is derived from bile. Liver actively transports into the bile organic acid, especially during glucuronides of OATP and MRP2. Organic bases by OCT and other lipophilic drugs by PGP and steroid by distinct non-specific active transport mechanism. Relatively large molecules of molecular weight greater than 300 are preferentially eliminated into the bile. Most of the free drugs in the gut, including that released by deconjugation of drug glucuronides by enteric bacteria, is reabsorbed. Enterohepatic cycling and ultimate excretion occurs in the urine. Figure 3.2 Enterohepatic cycling of the drug. In the liver, the drug D is glucuronide leading to G deconjugation. Then it enters into the intestine via bile duct, where the bacteria deconjugates the drug, and the drug is reached back to the liver via portal circulation, and the conjugated compound is excreted. The drug glucuronide combination can also enter into the kidney and excreted via urine. So, in the liver, many drugs, including the steroids, are conjugated by the enzyme UDP glucuronyl transferase UGTs to form the drug glucuronide DG. Part of the drug enters the systemic circulation and is excreted into the urine by the kidney through both glomerular filtration as well as active tubular secretion involving renal organic anion transporting polypeptide or ATP. Another part of DG is actively secreted into the bile by the hepatic or ATP. On reaching the gut lumen via bile, a major part of the DG is deconjugated by bacterial hydrolytic enzyme deconjugase, while the remaining is excreted in feces. The released D is reabsorbed from the gut to again reach the liver through portal circulation and complete the enterohepatic cycle. Only the remaining is excreted in the feces. The enterohepatic cycling contributes to longer stay of the drug in the body, which is the probable reason for its toxicity and its effectivity. Both drugs that attain high concentrations in the bile include erythromycin, ampicillin, rifampicin, tetracycline, oral contraceptives, vicuronium, and phenolphthalein. Certain drugs are excreted directly into the colon, for example, anthraquinone, purgatives, heavy metals. Third, exhaled air. Gases and volatile liquids, general anesthetics, alcohol are eliminated by lungs irrespective of their lipid solubility. Alveolar transfer of a gas or a vapor depends upon its partial pressure into the blood. Lungs also serve to trap and extrude any particulate matter that enters the circulation. Fourth, saliva and sweat. These are the minor important for drug excretion. Lithium, uh, potassium iodide, rifampicin, heavy metals are present in this secretion in significant amounts. Most of the saliva, along with a drug in it, is swallowed and meets the same fate as orally taken drugs. 5. Milk. The excretion of the drug in the milk is not important for the mother, but the suckling infant inadvertently receives the drug. Most drugs enter the breast milk by passive diffusion. As such, more lipid soluble and less protein bound drug crosses better. Milk has the lower pH than plasma. Basic drugs are somewhat more concentrated in it. However, the total amount of the drug reaching the infant through the breastfeeding is generally small, and majority of the drug can be given into lactating mother without ill effects on the infant. Nevertheless, it is advisable to administer any drug to a lactating woman only when essential. Renal excretion. The kidney is responsible for excreting all water soluble substances. The amount of drug or its metabolite ultimately present in urine is the sum total of glomerular filtration and tubular reabsorption and tubular secretion. Efferent arteriole, glomerulus, plasma protein, lumen, tubular cell, urinary pH, peritubular vessels. The schematic depiction of glomerular filtration, tubular reabsorption, and tubular secretion of the drugs: free drug, bound drug, unionized drug, ionized drug, actively secreted organic acid or base drugs. Glomerular filtration. Glomerular capillaries have pores larger than the other capillaries. All non-protein bound drugs, whether lipid soluble or insoluble, presented in the glomerulus is filtered. Thus, glomerular filtration of a drug depends on the plasma protein binding and renal blood flow. Glomerular filtration rate normally is 120 ml per minute, declines progressively after the age of 50, and is low in renal failure. Glomerular filtration of drug declines in parallel. Tubular reabsorption. This occurs by passive diffusion and depends upon the lipid solubility and ionization of the drug at the existing urinary pH. Lipid-soluble drugs filtered at the glomerulus back diffuse in the tubule because 99% of the glomerular filtrate is reabsorbed, but non-lipid soluble and highly ionized drugs are unable to do so. Thus, the rate of excretion of such drugs, for example, aminoglycoside antibiotics, quaternary ammonium compounds, parallels GFR or creatinine clearance. Changes in urinary pH affects tubular reabsorption of the drug that are partially ionized. Weak base ionize more and are less reabsorbed in acidic urine. Weak acid ionize more and are less reabsorbed in alkaline urine. So base will be unionized in base and will be ionized in acidic. This principle is utilized for facilitating elimination of the drugs in poisoning. That is, urine is alkalized in barbiturates and salicylate poisoning. Though elimination of weak base, morphine, amphetamine can be enhanced by acidifying urine, This is not practiced clinically because acidosis can induce rhabdomyolysis, cardiotoxicity, and eventually worsen outcome. The effect of changes in urinary pH on the drug excretion is greatest for those having pKa value between 5 to 8 because only in their case pH dependent passive reabsorption is significant. Tubular secretion, two separate class of relatively non-specific transporter OAT and OCT operate in the proximal tubules and actively transfer organic acids and base across the tubular epithelium. In addition, efflux transporter PGP and MR2 are located at the luminal membrane of proximal tubular cells. If renal clearance of the drug is greater than 120 ml per minute GFR, additional tubular secretion can be assumed to be occurring. Active transport of a drug across the tubule reduces the concentration of its free form into the tubular vessels and promotes the dissociation of protein-bound drug, which then becomes available for secretion. Thus, protein binding, which is a hindrance for glomerular filtration of the drug, is not so, may even be facilitatory to excretion of tubular secretion. A. Organic acid transport through the OATP operates for penicillin, probenecid, uric acid, cyclates, indomethacin, sulfenpyrazone, nitrofurantoin, methotrexate, drug glucuronide and sulfates, etc. Organic base transport through OCT operates through thiazides, amyloidine, triamterene, furosemide, quinine, prosinamide, choline, cimetidine, etc. Inherently, both transport processes are bidirectional, that is, they can transport their substances from blood to tubular fluid and vice versa. However, for drugs and their metabolites, exogenous substance secretion into the tubular lumen predominates, whereas an endogenous substrate like uric acid is predominantly reabsorbed. Drugs utilizing same active transport compete with each other. Probenecid is an organic acid which has high affinity for tubular OATP. It blocks the active transport for both penicillin and uric acid, but whereas net excretion of the former is decreased, that is, the latter is increased. This is because penicillin is primarily secreted while uric acid is primarily reabsorbed. Many drug interactions occur due to competition for tubular secretion. Example, aspirin blocks urosuric action of probenecid and sulfenpyrazone and decreases tubular secretion of methotrexate. Probenecid decreases the concentration of nitrofurantoin in urine, increases the duration of action of penicillin or ampicillin, and impairs the secretion of methotrexate. Sulfenpyrazone inhibits the excretion of tolbutamide. Quinidine decreases renal and biliary clearance of digoxin by inhibiting the efflux carrier PGP. Tubular transport mechanisms are not well developed at birth. As a result, the duration of action of many drugs, for example penicillin, cephalosporin, aspirin, is longer in neonates. This system matured during infancy. Renal function again progressively declines after the age of 50 years. Renal clearance of most drugs is sustainably lower in the elderly. So kinetics we will cover in next video.